In this Module 3 video, we'll be covering risk adjustment. Our objectives are to identify the 3 factors that can change healthcare costs in a capitated payment system, identify factors related to healthcare utilization, describe why it is important to account for patient complexity through risk adjustment in capitated payment systems, and finally discuss how epidemiology is useful in conducting risk adjustment. So as we've said before, risk is the probability of experiencing a health event or disease. In the context of healthcare utilization, we might want to quantify the risk of using healthcare. And there are contributions to this that are both random and systematic. If you recall, earlier we talked about random and systematic error in the context of statistics, and it's kind of the same idea here. Random contributions to healthcare utilization are those that are difficult to predict and not associated with any particular patient characteristics, while systematic errors are those that we can identify and quantify. And when we're thinking about healthcare utilization, systematic factors that relate to healthcare utilization generally relate to people's health conditions and diagnoses, but they also relate to their previous utilization history. And then, as we said, the current conditions and current risk factors play a role, along with community risk factors. So if you were to make a diagram of all of the factors that could impact someone's likelihood or risk of using healthcare services, here's an example. Things like demographics, age, sex, race, ethnicity, their insurance coverage, both whether or not they have insurance, the type of insurance they have, what their co-payment structure is like, the availability of healthcare in their area, their physical and social environments, the health conditions they currently have, their attitudes and beliefs about health in general and healthcare systems in particular, and cultural traditions. All of these, along with many others, probably impact someone's use of healthcare. And so it can be a challenge to predict healthcare utilization, but it's an important challenge to try to address, especially in the context of capitation and capitated payments. So capitated payments, as you may be familiar with, are fixed payment amounts from the payer to providers per member per month. So the idea behind capitated payments is that it shifts some of the financial risk to providers and incentivizes providers to provide more efficient care. In this kind of system, in a capitated payment system, the only ways to lower costs are to enroll healthier patients, so lower patient risk profiles, to increase the efficiency of healthcare services provided, or to change the quality of healthcare services. So when we think about capitation payments, the first thing that may come to mind is if you're being paid a consistent per member per month rate, that might not adequately cover some patients that you're likely to see. And here's an example. We have 2 theoretical patients here. On the left is an 87-year-old man who walks daily, who's been diagnosed with arthritis, congestive heart failure, and prostate cancer. And he sees his primary care provider and 2 specialists every 6 months. On the right, we have a 42-year-old woman who rides her bike for transportation. She has an asthma diagnosis and sees her primary care provider annually for her well checkups. Now, if we're predicting utilization and looking at these 2 different patients, we might reasonably expect that the 87-year-old man would have higher utilization than the 42-year-old woman. He has more diagnoses. He already has a plan under which he is seeing providers at least 6 times a year. And it's likely that he may develop additional health problems in the near future. So if we were being paid the same amount for these 2 patients, we may have difficulty covering all of the care and resource needs for the 87-year-old man, while we may have a surplus of funds if we were covering the 42-year-old woman. This is kind of a confounding problem. So if we picture it as using our covered patients and trying to identify their healthcare costs, seeing whether our patients are associated with higher or lower healthcare costs, utilization could sort of be seen as a confounder here, that our patients would have different levels of utilization depending on their characteristics, and that utilization we know is associated with cost. That's a main driver of healthcare costs, which is really why we're interested in understanding and predicting utilization. So one way that we use to account for these differences in our patients and to try to get a more accurate or fair a capitation payment for patients who have higher costs, higher likelihoods of utilization, is to use risk adjustment. So the idea behind risk adjustment is to account for person-level differences across patient groups so that those capitated payments that we're receiving from payers reflect their likely healthcare utilization. Again, if all providers received identical payments per person, the incentive would be to restrict your practice to those healthier patients, the one like the 42-year-old woman, who are pretty healthy, and therefore we'd have higher profits. We'd have surplus of money after providing all of the care that she needed, potentially in a year, rather than having a shortfall. But that's not the ideal situation. We said before that the ways to lower costs in a capitated payment system, one is to restrict our enrollees, but we don't want to do that from a population health perspective. We don't want to leave people who need health care the most, who have health conditions already, without coverage. Instead, we'd like to incentivize providers to increase efficiencies or change quality in a way that lowers costs. So risk adjustment is one way to do that. If we provide payments for members that is based on their likelihood of utilizing services and reflects their likely resource needs, then we incentivize providers to focus on those efficiency and quality changes rather than cream skimming or cherry picking or whatever metaphor you want to use for picking healthy people. And how does this relate to epidemiology? Well, we need a number of pieces of data in order to make risk adjustment work. First, we need accurate health status and demographic information on our population. We need reliable estimates of healthcare utilization for different diagnoses and risk factors. And we need a statistical model that adequately represents variability in utilization and accurately classifies people's risk or category based on their characteristics and the healthcare utilization information we have. So where can we get some of this data? One option is to use patient surveys. So this would allow us to collect data on topics that we wouldn't have information on through the medical record. So some of those external factors, community level factors, social context, health beliefs, cultural beliefs, and influences could be collected via a patient survey. These could be resource intensive and might be difficult to administer, but could give us that added information beyond just health status, diagnoses, and previous utilization. It's worth noting that these could be subject to information bias, so some patients may not respond, and those who do respond may feel like they need to report things in a particular way, given that they would know it was coming from their provider. It would also be important to have some kind of backup approach for missing data. So if we have lots of missing data, we may need to throw out individuals in the analysis phase. So having follow-backs or having some other sources of information for missing data would be an important consideration. Another good data source is the medical record itself. This would give us a comprehensive picture of the care that was provided within the system, but here it's important to note that any care provided without or outside of the system wouldn't necessarily be captured unless those medical records were added into our EHR. And it's most helpful if we have a standard data entry procedure in medical records. It's very time consuming to read through chart notes individually. So if there were forms, boxes, or a natural language processing program that could go through and extract the information that we needed to create our risk adjustment scores, that would be the ideal scenario. Finally, we could potentially use claims, and these would be comprehensive for reimbursable care within our system. So keeping in mind, as we've discussed before, that the purpose of claims is for revenue, not necessarily for healthcare delivery or evaluation. So we would be restricted in that sense to the types of coding procedures that are used within our system and the types of care that are reimbursable. So if things can't be reimbursed for, they would not show up in a claim, and so we wouldn't know that they happened. So these also are subject to information bias for those reasons. We would want to think, again, carefully about our scope of measurement. Although we recognize that there are systematic factors associated with utilization at each one of these levels, of influence, it might be very challenging to incorporate society or even community level factors or pieces of information into our risk adjustment models. So we likely would largely focus on individual factors. We may have some interpersonal level information about family structure, care provided by others, that sort of thing. And at the organizational level, we could certainly include our own organization's characteristics in our risk adjustment model, but we would likely be limited in incorporating the full spectrum of influences on utilization in our modeling. So one example of doing this, of accounting for patient complexity through risk adjustment, is the use of diagnosis-related groups, or DRGs. This is a way to group clinically similar patients with similar resource intensity together. And it developed out of the recognition that using hospital-level information alone is insufficient to predict resource use or utilization. So previously, things like the hospital's teaching status or the number of beds were used to predict costs, and they really were not sufficient. So in 1983, there was an amendment to the Social Security Act that made DRGs the basis of Medicare hospital reimbursement, and as a result, they've been used much more broadly since then. And DRGs really relate the patient case mix complexity to hospital costs and resources. And so this is not just, as the name implies, they're diagnosis-related groups, not just diagnosis groups. So it's not just about the condition or conditions that patients are diagnosed with. It incorporates these various factors: severity, their prognosis, difficulty of treating that condition, the need for intervention, and then the intensity in terms of resources of treating that patient. And if you're interested in reading more details about DRGs, how they're constructed, there's a link at the bottom there to the full code manual for DRGs. The goals of developing DRGs were to incorporate information that's routinely collected in hospital systems. So they should be relatively straightforward to collect and construct. They also wanted to create a manageable number of DRGs that could encompass all patients that were seen on an inpatient basis. So manageable here is somewhat relative. There are hundreds of DRGs, but the developers recognized that thousands would be unwieldy. So kind of limited it to the smallest number possible while still being informative. Another goal was that each DRG should have patients with a similar pattern of resource intensity. And finally, from a clinical perspective, the developers wanted DRGs to be meaningful to clinicians. So initially, the approach was to use physician input to come up with this list of diagnosis-related groups. And that's represented on the left in this figure. And physicians, when they sat down and tried to work out what kinds of patients were similar and which, in terms of their resource utilization and diagnoses, there were just too many DRGs. So this did result in thousands of different DRGs, because clinicians tended to subset patients based on clinical specialty, but then had lots of different exclusions and inclusions in terms of different DRGs. And so they just came up with too many groups. So an alternative approach was to use a statistical algorithm to predict resource utilization. And so this did a really good job of segmenting costs, coming up with really homogeneous groups that were highly predictive of healthcare utilization, resource costs, but they weren't particularly clinically meaningful. So patients with very disparate conditions would end up in the same DRG. And this wasn't very useful from the clinician's standpoint, because it wasn't meaningful in terms of what they should do, because they didn't think there were patients in the same group that they never felt like they would see together. So the final approach merged these two different approaches and came up with a version of DRGs that was both clinically meaningful and highly predictive of costs, but not as clinically meaningful as the physician input alone, and not as predictive as the statistical algorithm. Here's an example of a typical DRG structure, and they start with these major diagnostic categories, of which there are 25, and these are 25, these are mutually exclusive groups that correspond to a single organ system or etiology. So this checks the box of being clinically relevant and coherent. And some examples include diseases and disorders of the eye, burns, pregnancy, childbirth, and so on. On the right is a figure that shows a typical flowchart of how we would get from this major diagnostic category down to a specific DRG. So here, for example, let's say we were looking at the diseases and disorders of the eye as our MDC. Our first branch point might be whether or not there was an OR procedure involved. If so, we'd want to know the type of surgery and classify it as major, minor, other, or a surgery that wasn't related to the principal diagnosis. And from there may be additional branch points to get down to a specific DRG that helped us understand the potential cost, the resource utilization of the patients who had eye diseases or disorders and underwent surgery. So far, we've talked about risk adjustment in the context of setting these per member per month fees appropriately in a capitated system, and that is largely what they are used for. But it's also possible to do it from the other side, in which we could use risk adjustment to set premiums for individual enrollees. And I won't talk too much about that here, but case study 8.2 in the textbook is one example of this if you'd like to read more. One thing worth noting when thinking about risk adjusting and capitated payments is going back and thinking about the focus on prevention, the impetus to do prevention at a community level. If we can improve community level health status, that could reduce utilization across all of our members within a healthcare system. For example, this is a very broad intervention and may not be feasible for many healthcare systems, but if we made neighborhoods more walkable, we know that that might increase physical activity, which in turn could reduce all kinds of chronic diseases and might thereby make our patients need fewer resources, have lower healthcare utilization. And that's what we want to do. Ultimately, we want to improve population level health. But the question becomes, if providers are successful at preventing negative health outcomes and high cost conditions, would that backfire in the form of lower per member per month payments in a capitated system? And people have thought about this, but it's a challenge to come up with risk adjusted capitation approaches that account for chronic risk factors and reward providers who decrease risk factors. So in other words, we just need to continue to make sure that our incentives are appropriately aligning with our overarching goals, so that if providers are successful in reducing community level risk factors, preventing negative health outcomes and exacerbations of disease, that they're not then penalized in the form of lower per member per month payments. Finally, risk adjustment can be used for quality evaluations. So it might be appropriate to risk adjust quality measures when you're comparing across providers or systems when there are two very different patient populations. So this is an example of a confounding problem. So here we have providers, and we want to know if our providers are associated with higher or lower levels of care quality. But patient health status would confound this association. So if our providers are providing care to more complex patients than another group of providers, those patients would likely result in our quality of care measures looking poor, just because they would need more treatment and therefore would potentially have more of those ambulatory care sensitive conditions, or be hospitalized more frequently for those conditions. And so it would make it look like our providers were providing lower quality care, when in fact it was just a reflection of differential patient health status in the underlying populations. So we could risk adjust our quality measures to more evenly compare across systems. And there's a case study in the textbook, it's back in chapter 5.2, that looks at risk adjusted complication rates in a small rural hospital as an example of a way to risk adjust quality measures. So in summary, in a capitated payment system, it's important to measure, understand, and account for patient complexity since it relates to utilization and resource intensity. Demographics, prior healthcare utilization, current health conditions, Health behaviors and risk factors and community risk factors are the systematic aspects of utilization that we can measure and evaluate and use to develop risk adjustment. Epidemiologic approaches and methods can be used to identify these factors associated with utilization, to measure patient complexity, and to model predicted utilization and cost to better understand patients and their needs.